Tell us a little bit about how you, when people are at those last moments of life, reframe hope.
I get a little emotional, sorry.
And in the end, he looked at me and he was like, "Thank you so much." He goes, "I didn't think there was anything to be here for anymore."
Welcome to The Leadership Table, a podcast of Roberts Wesleyan University where we explore how faith, learning, and leadership intersect to equip whole person transformation. Here we sit down with students, faculty, alumni, and thought leaders to share stories and strategies that shape the mind and spirit for meaningful impact in today's world. In today's episode, we talk about what it means to walk with people at the end of life, with honesty, compassion, and care. You'll hear from a nurse practitioner, a hospice and palliative care physician, and a chaplain as they share real stories about finding peace, purpose, and even hope in life's final season. So pull up a chair, take a seat at the table, and let's listen in.
Well, thank you everyone for being here. I really do appreciate it. I would love for you to introduce yourselves to folks and tell us something fun that you did over the weekend. So, go ahead.
Okay, I'm Jennifer Tuttle. I am a nurse practitioner. I'm also the director of the Family Nurse Practitioner Program at Roberts Wesleyan. My primary practice is in hospice care. And something fun over the weekend, I went ballroom dancing.
I'm Jonathan Steiner. I'm a hospice and palliative care physician at Unity Hospital. As far as this weekend goes, I just spent a lot of time with my wife and kids.
I'm Rebecca Draper. I'm a faculty member here at Roberts. I teach in the social work program. And a fun thing I did over the weekend, I went to my niece's bridal shower.
Oh, lovely. And for the audience who might not know me, I'm Anne Marie Dallin Castronovo. I'm Dean of the School of Nursing here at Roberts Wesleyan University. I have a background in advanced practice, palliative, and hospice care, so I'm delighted that we're doing this podcast. Thanks for being here. I really do appreciate it. I think we'll start with one of the things that I hear pretty frequently. What exactly is palliative care? So many patients and families, they may hear palliative care and they immediately think end of life. So how do you address that?
So palliative care is, it's really a focus on quality of life and symptoms, and that's at any time of a serious illness. So from the very beginning up to the end of life. I think a lot of times people just associate the end of life because that's sometimes when we can be more involved than other times.
I like to think of palliative care as being the umbrella that hospice falls under. So, in other words, palliative care is the idea or the care of symptoms at any point, as Dr. Steiner said, of a serious illness. And then hospice kind of falls underneath that umbrella in that it's a very specific time of the end of life. So with a 6-month or less prognosis, then hospice services can be initiated. And again, it's a focus on quality of life. It's a focus on symptom management, much like palliative care, but the time frame is very described and prescribed.
And how do you find it trying to tell the next generation of social worker students and how they will help to kind of untangle this?
Yeah, I agree with a lot of what was said. And I think one of the things that we would focus on is helping families and patients to understand that palliative care doesn't mean you're giving up hope or that you're stopping treatments, that it is about quality of life, but you can still be looking for a cure. You can still be looking for healing, even while you're under that kind of umbrella.
And so similarly, I think when patients and families are then offered hospice as an option, what do you see as those initial reactions?
Sometimes there can be a little bit of hesitation or worry that if they sign on to hospice, that means that's it, they're giving up. And it really is just a change in philosophy. Instead of focusing on curative interventions. Instead, we're being really aggressive to make sure people are comfortable and making the most of the time that they do have left, so that those goals, those things that are really important for them, that we can find a way to make that happen.
To add to that, I would say, patients can also come to us very ready, having had discussions with family and finally coming to a place where they've decided, I want to focus on comfort. I'm tired of fighting this hard and being uncomfortable. And it's almost a relief. It's almost a release for the patient and the family when it's something that's been a long process or even not, but there is a true communication between family and patient about what their desires are. And it can be a very liberating decision in some ways. And I've seen that way as well.
Yeah. I think that providers have to be prepared for a multitude of different reactions to that we might go in thinking like, oh, people are going to be so heartbroken that we're at this stage where hospice is necessary. But you could actually find people, who are very relieved and ready for that. So you have to be prepared for anything.
So I think too, in my practice, we met with a lot of folks, well, I don't have cancer, right? And I think a lot of our work, whether it was palliative care or hospice care, really started around folks who were diagnosed with different cancers that didn't have the treatment options that we have today, where cancer now has become a chronic disease, right? And so if you were to tell the public listening, right, and they're just trying to figure out, well, what kind of diagnosis? What's a serious illness? If you were to think of what you frequently see in your day-to-day practice and caring for people.
I think really anything that's life limiting, and also that has a symptom burden associated because of that. So that could include things like COPD or heart failure, kidney disease. Those are all things that could be, considered a serious illness.
And I would include things like Alzheimer's, dementia, some of the neurologic conditions, toward the end of progression, multiple sclerosis, and some of those. So anything really that is a chronic illness that is, as Dr. Steiner said, life-limiting can be considered. So we see diagnoses all across the spectrum.
Any that stand out to you?
No, not necessarily, but I do think that is a good conversation to have with folks is kind of demystifying what we're talking about, and the fact that you're right. I think there's a stereotype of like, I have to have a cancer diagnosis to qualify or to receive services. So
I think one of the things that I learned to help really tease out the difference between palliative care, right, and hospice care, and it's almost like, I'm going to use the example with the kidney disease. So I think the public may be familiar or even may know somebody who's had end-stage renal disease, and they have providers who are making the challenging decision based on laboratory work and all the other testing that somebody's been through, and making the decision that part of the plan of care now has to include some kind of dialysis. And so there are folks that say that in that time period, that patient would benefit greatly from palliative care. And so if we use that as an example, what would be some of the things that you would want that patient and their loved ones to know about palliative care being introduced at that point in time?
I think for me, it goes back to, again, that we're not at a point that we're giving up hope, that we think that this is, that you can't continue to live, with some quality of life, but that there's, this is, it is about how do we provide you those treatments, but also in the way that and in this moment, your quality of life is as good as it can be.
Yeah, and I think I would add too that, quality of life changes throughout a disease process, and why not have an extra support to be able to talk about those things? Because I think all too often people get these treatments and don't always know or get the education about what's this going to look like in 5 years or 10 years, and it's what's my life going to look like. So we can help talk about expectations, because sometimes wondering can be the worst thing for people. At least that we can help them have a plan and more information to help them,
Right.
plan for that.
And I think when you say talking about their expectations, I think what I have found so amazing about palliative care providers and the team approach is about they quickly can create an environment, sometimes in the middle of chaos, right, for families. And start to be able to give that space and dedicated time for really challenging conversations. Can you maybe speak a little bit about how you're able to do that, and sometimes fairly quickly?
I think a big part is meeting people where they're at and just asking open-ended questions. I found that doing that they'll say what they're really thinking, even if they don't realize it, and we can just pick up those cues. And I found that sometimes when there's the most chaos, having those conversations, even though there might be some distress or hesitancy at first, as soon as that conversation starts, it's kind of like a flood, and they just want to hear more, and they're eager to hear that what they've been maybe avoiding or asking but not getting the answers they've been looking for.
I would say, in palliative care, we're well suited for that. We're that extra layer, and, we're coming in for the support and for education, and we're not necessarily talking about curative processes and things. And I think some providers, when they're, say, the endocrinologist or whomever, it's hard to talk about what happens when. What happens if we can't cure this or we're not going to get better? Whereas when we go in, that's really what we're open to hear and what we're open to learn about. So it's a different interaction with patients and their families, and we ask the difficult questions and we open the difficult doors. And sometimes just being the new face in the room and being able to listen and, like you said, meet them where they're at and broach those subjects allows patients and families to start thinking on really different ways. And it's almost a permission.
So it sounds to me that you create an environment where a lot of honesty can emerge. And can you maybe share some thoughts about how honesty in and of itself can offer some comfort and healing?
Yeah. Sorry.
No, go ahead.
I think sometimes, even if it might not be news that people want to hear, a lot of times I've been thanked for giving very difficult news, because they've been saying, I keep doing this treatment and I don't know if I'm getting better or not. And my doctor just says, yeah, just keep getting this treatment. And, thank you. Now I know, I can plan around this,
Yeah.
I think that honesty is so important too, because, patients are not blind. They're not deaf. They're not, for a better word, they're not dumb. They know that things are happening. They don't know, and oftentimes I think they walk away sometimes from different providers going like, I don't know, like there's something happening, but no one's really saying it. And once they can be with a team who can lay it all out and here are all your options, here's what's happening. I think that there's so much, I think that trust can happen very easily because they feel like someone's finally, and again, I'm not saying that service providers are purposely not telling them things, but their focus is a little different than a palliative team who can, put all of it out there and talk about it.
And it's the proverbial elephant in the room, right? We bring the elephant out and we gave it a name and we talk about it openly, and we're although difficult, we're comfortable in those situations, and patients begin to realize that we are honest and we will answer honestly. I frequently will ask permission to share what, I have to say, to give them that option. And so giving them control over the conversation in some ways is also very important, but developing that honest, open trust is paramount in the relationships that we build with our patients.
So talk about that trust. How do you develop that trust?
I think it starts with the patient. A lot of times we're trained to go in with an idea, with a plan, and sometimes we have the luxury that a lot of other providers don't have to just sit down and say, "How are you?" And I think it just starts with listening. I think that's the most important thing.
I would say it starts very much with listening, presence, giving patients and families time. We're not rushing in and rushing out. It's not a timed event, but we give them presence and time. And just in being present, you open up an area of trust. And then I think people are called to hospice and palliative care. And in that calling, we have certain gifts that allow us to be present, to be open, and have these conversations. So I believe that's something we bring into the space that helps with that trust forming.
I'm sure that, you have so many different stories of a palliative case, a hospice case. What's one that taught you the most about how to move forward with lessons learned?
I had this hospice patient once, and I get a little emotional. Sorry. He was passing away and facing end of life, and he and their family, their biggest concern was their child. How are things going to turn out for them? Are they going to be okay? And for context, my own father passed away when I was a kid and about the same age as their child. So I usually keep things, professional. I don't talk too much about my own personal life, but I really felt like an opportunity that needed to be shared. So, we had a lot of emotions after talking about that, and they were at so much peace afterward. And we all acknowledged that God had brought us together, that was specifically for that time, and gave them a lot of peace, that something I'll never forget. But that helped me to show that, being a physician isn't just, keeping things professional always. There needs to be some involvement. So now that helped free me a little bit to be more personable, to share my faith a little bit more. Because that's how I practice, because that's who I am, and trying to separate those two is, I think, impossible.
Mm-hmm. And I almost think that that's, you're taking all the science that and then you're practicing, and with each case, with each person, you're honing, right, the practice and learning the art and learning when it's appropriate and maybe when it's not appropriate. And so I think that that's important and meaningful, especially if anybody's listening and they're a medical student, a nursing student, a social work student, etc., to understand that, and to also have debriefing episodes, right? Where I think that's a lot of the work that up until this point we haven't spoken about, but how we have our teams that we work with and how we do a lot of debriefing and self-care and resilience measures to be able to make sure that we're as healthy as we can to keep doing the work. So thank you for bringing that up.
So, a story about a case that taught me a lot. There was a younger gentleman who was admitted to our inpatient hospice unit, and he had throat cancer, and he had a chest tube. The chest tube, he had a fistula between his esophagus and his lung. And so anything he ate or drank went through to the chest tube and out. And, this was a a big deal, to have to care for him. And so he came to our inpatient unit, and his one hope, his one desire was to go home. And everyone sort of looked at him and said, "No way, we cannot care for you in your home." And his wife looked at me one day, and I was kind of in the same thing, like, wow, this is a lot. This is a lot to care for at home. I'm not sure we can do this for you and for him. And she looked at me and she goes, "Is there any way?" And I went, "Well, let's think about it. Let's figure it out." So I got our team together. I got our social work team and, our provider team who covers the community and our nursing team. And we all got together and we talked about a plan for transitioning him home. After a weekend of the wife providing all of his care for him and doing all the things and training with the nurses and learning how to turn and learning what to do in an emergency if something happened with that chest tube and how to deal with emergency medications, we sent him home. And he was home for 2 weeks and he got his wish. And the day he passed, his daughter called the unit, and I happened to be on again, and she was scared. And she's like, "I think it's time. I need to know how to use that medication again." And I said, "Okay, I can help you." And we talked it through. He stayed home. He passed at home, surrounded by his family and his friends. And his daughter came in about a week later, and she goes, and I'm going to get emotional. "Thank you so much for thinking that we could do this at home, because no one thought we could. And it was the most important thing we could have done for our dad." And I went, yeah, it taught me a lot that we have to be able to think outside the box in order to provide every opportunity for the quality of life that the patient is desiring. So that was that was a really impactful patient and family to care for me. It just reminds me that we can do things that we don't always imagine we can.
And I think what's so beautiful is just knowing all the different cases, right? Not everybody wants it to unfold that way, right? And that you were able to do that individualized care, I think is so meaningful, because I think it's important to let listeners know that hospice is not a place, right? And I know we've spoken about this before. It isn't always in a hospital or in a nursing home or in a standalone building that's dedicated to hospice, that it can be in the community. It's all about assessing the situation and what are the resources at any given point in time. And how about memorable moments for you, either teaching or caring?
Well, so one of the places or one of the ways that I learned a lot about how people, like good quality hospice care is I had a family member who was in hospice. And so it's always an interesting opportunity to see, how does a social worker do this work when you're on the side of the family? And that was it was a hard experience, but it was also a great experience to see some of the things, like you were saying, how individualized, hospice could be. I remember they're like, well, we could introduce this or we could do that. And what would your loved one want? And, like, would they want music therapy, or what are the things that we could provide? And I walked away from that, again, just having such a clear idea of, like, what are the expectations? How do we support people who are facing end of life? And how do we do that in a way that honors them and the family and provides them what they need?
That's great. I mean, the options are, I think, so important, and the individualized assessment. I'd love to share with you one of my most memorable patients. He came to us, had resources, so we had a small outpatient practice for palliative care. And he came to us, and he had been labeled a drug seeker. And he was somebody who had longstanding HIV. Had developed various complications because of it, including having head and neck cancer, which he had surgery for. And he had a really nasty condition called trisbus. Am I saying it right? I have, and so that means that he could not eat without having pain. He couldn't open his mouth. He couldn't brush his teeth good. And he clearly had discomfort. And so once we assessed and got his old records, because he also was coming to us brand new, and we did what we are taught to do. We did a thorough assessment. We checked all the state records because we're heavily regulated because of the medications that we use, opioids and anxiolytics, etc. And we did all that, and we got him into a contract. And so again, in certain settings, we'll have a patient, best practices, sign a contract. We go through all the safety of the medications and such like that, so that we're doing due diligence. And we did get him comfortable. Probably about a year into caring for him, we got him connected with a really good speech and swallowing therapist who was able to teach him strategies that other providers he had seen had not taught him. And so he really did get to a comfort level with low dose types of medications and such like that. And then after about a year, 18 months, he did have a reoccurrence. And so we followed him every step of the way. He was admitted. He had a very invasive type of surgery for that repeating cancer. And it was seen as more palliative than curative. And I remember he had a prolonged hospitalization. Almost every member of our team, we had a clinically trained chaplain who would work with him. And he had been somebody who had refound his faith, and that provided him a lot of comfort. He was discharged, and I want to say 8 months after that. You can start stacking the time, right? About 8 months after that, I got a phone call. So, Anne-Marie, somebody's here to see you. So I went to our office, and sure enough, there he is standing, smiling, and giving me an entire update on his life, thanking our team because we advocated for the surgery. We had a really good surgeon who was open to doing the complicated surgery and such. And he had actually gotten off of opioids for pain, right? Flash forward, he then had a couple of other bouts with other different types of cancers. We cared for him over the course, we put it together, of a little over 5 years. And I think that was a really great case for palliative care when you look at literature of how palliative care not only affects quality, but that we can argue that we're building evidence that it can also improve quantity of care. And then, of course, at some point, he did shift to our pals in the hospice side. And it was a much easier, so to speak, transition. And he was very much at terms at that point at his life. But I think it really taught me so much and gave me so much. And he was somebody who actually had done some counseling for people. And he came to a class and taught my students with me. And so I think there's just such human resilience in the work that we all do, whether it's from that palliative lens or from hospice. Tell us a little bit about how when people are at those last moments of life, so it could be days, weeks, months, right? How do you assess and then help reaffirm or reframe hope? And maybe you even have a story about that.
Okay, I'll go. So that's a difficult question, and something that I believe Dr. Steiner would agree, we do get questions about or asked a lot about from our patients and families. Well, how can we have hope at end of life? How can we have hope when we're electing hospice and we're giving up? And we've talked about philosophy or, hospice not being a place, but being a philosophy. And I think that's where I lean in when I have those conversations with patients, is that it's a philosophy of hope for quality of life, of hope for making the most meaning out of what time we have remaining, dealing with the inevitable process, the natural process of death, in a meaningful way that allows patients to work at legacy and understand what they're leaving behind, allows families to soak up, I use this a lot, soak up a lot of all the love that they have, that they can soak up from their loved one, and give all the love they can give them in those final days, and making sure that we're doing that while the patient has being cared for in a dignified way. Their symptoms are being managed so that they can concentrate on the really important work, the really hopeful and important work at end of life. So that is how I try to help patients and families refrain it. And I think of a patient that I cared for not too long ago, and they were young, didn't want to die. Of course not. There was much to be done. There were children to take care of. There were weddings to attend. There were so many dreams that were not going to be fulfilled. And they looked at me and said, "How is there hope? I'm hopeless." That's a tough question. And I looked at him and I said, "Well, what do you hope for?" He goes, "Well, to live longer." I'm like, "Okay. What do you hope for in that time that you live longer?" He goes, "Well, that I can hug my children." I'm like, "Okay." Like, "So we can have your kids come in and we can hug and do that." And we'd had a whole conversation about where the hope lies and where he could find areas of hope. And in the end, he looked at me and he was like, "Thank you so much." He goes, "I didn't think there was anything to be here for anymore." He goes, "But I got a lot of work yet to do to ensure that my children know that I love them, even though I can't be here for the rest of their lives as I wish I could be." And he's like, "So I guess I've got to be a role model and show them that there's hope even in the greatest despair." Yeah, couldn't have said better myself. And he was then did much work at the end of life with being hopeful about what those days could look like, rather than focusing on the giving up aspects.
When you were talking and you were sharing some of the word choices, it made me remember a few social workers who had done quite a lot of work in ends of life. And they would often say the hope was helping people make sure that they understand it all comes down to love and forgiveness. And so when I hear you share that I have a lot of work to do to be the role model, I'm kind of reading in between those words and thinking there's like tidying of loose ends. And does that resonate with some of the cases that maybe some of you have worked with?
Yeah, and it's not only the patients, but it's the families because we're social. We're all, connected with other people. And I've had patients at the end of life who, because of their faith, they were just looking forward to seeing their spouse again. They were, you know, they had that hope, that, that eternal, that big picture hope. And I've also had some families come together where siblings, I remember these two sisters from opposite ends of the country came, like, "Oh, we haven't seen each other in so long. We get along so well. And, we want to be with mom." And mom decided to take more time than expected at the end of her journey. And every single day I got to check in with them, and they had these new conversations, these new memories, and they really said that, I think mom did this on purpose because the gang's back together. And, they use that as a springboard to plan ahead. They said, "Okay, we're never going to do this time away again. We're going to meet once a year.
Yeah.
We're going to reconcile, and have, make new memories like we used to." And, not that there was any dynamics or anything between them, but that they just wanted to make sure that they remembered what was important to them. So for them to be able to, spend that time together was, I think, fulfilling a little hope that they had for that week.
Yes.
And in that story, the between the lines that I'm picking up is the bits of humor that can happen where people least expect, right? And those moments are almost like pure joy mixed in with that hope. So,
And I do believe that we don't know. No, I often say this to my patients and families. We don't know what work is done at end of life. No one comes back to tell us. Nobody comes back and tells us what they had to do or what had to happen. But I firmly believe that there is work that is done, and it's personal and it's deep, and it requires solitude at times, and it requires support at others, and there's just obvious work that is done, and someday we're to understand. But in the meantime, all we can do is support in the best ways we know how that work that gets done, and respect that very important intimate time in someone's life.
And while it might not be necessarily connected to hope, but helping both patients and families recognize what a gift it may be to have that time to say goodbye, to reconcile, to do those things. Not everybody has that. And I'm not saying that all families would look at it, the gift of that, right, as they're grieving. But there really is, to help families maybe look at it through that perspective, that this is a gift this time because, yeah, you have time to do some of the work. Mm-hmm.
well, as we're wrapping up time for our listeners, what would be one bit of advice or wisdom that you would want to make sure that you imparted? Now's your chance.
Now's our chance. Wow. From the social work point of view, I would say to family members and to people, make sure that you have things in order. The power of attorney for financial things, and having a healthcare proxy, and have some of those conversations, as difficult as they are, having them ahead of time. Say it like that can be a tremendous gift, I think, as people enter hospice or palliative care, to have some of those conversations when people are healthy. They're hard. Don't shy away from them, though. That would be my word of advice.
Yeah, I second that 100%. And I think in addition to that, I think respecting people's wishes is so important. There are a handful of times where we've clearly heard somebody's wishes, and then the family member later on saying, yeah, but we want to do this. And it's tough, right? We want our loved one to be around longer. We don't want to say goodbye. And, they're, who knows what kind of emotions they have and the grieving that they're going through. So it can be really difficult to respect people's wishes, but I think it's a gift we can give to people to listen to them. And also, I think, give them the dignity that they deserve with that decision that they make in their healthcare proxy or MOLST or whatever it might be.
Mm-hmm. Because in some ways, it is brave when somebody makes decisions not to do the life prolonging curative treatments, that they have come to their own peace with certain decisions. And so I think that is really wise. Advice is to try to learn what those wishes are and honor those. And I think our younger generation is going to teach us a little bit about this, because they've been paying attention in ways sometimes that older generations haven't. So it'll be interesting what the future holds. And how about you?
So my piece of advice, they took both of my top piece of advice, which is, have the conversations. They're hard, but talk about it. Don't let it be the elephant in the room. Don't let it sneak up on you and be, in a crisis that we're having these discussions. Talk about it beforehand, even if it's, difficult. Make sure affairs are in order. Let your wishes be known, even though it's hard for loved ones to hear that, listen, I really don't want to continue dialysis anymore. It's too much. being able to have that space. But on top of all of that, I would say don't be afraid to ask questions. Don't be afraid to have a palliative care consult. If someone offers it, by all means, or ask, I have a chronic illness. I want to talk to the palliative care team. Don't be afraid of that, well, if I do that, I'm giving up, or, it's the end of the line for me. But that we could, as a palliative care team, really provide some quality of life measures that may just come underneath and support even the curative treatments that you're undergoing. So don't be afraid of that word palliative care or the word hospice.
Mhm. So tell me, how did you journey towards hospice care?
So for me, it was very personal. Again, with my dad having passed away when I was young, had a huge effect on me. And he was also a pastor. So I grew up in a Christian home, and um, I'm so grateful for that. And I think as a part of that, I felt a calling early on to do something like my dad, but not exactly the same kind of pathway. I remember all the time being asked, "You are going to follow in your dad's footsteps?" Like, I don't know. So a big part of my journey was figuring out what that calling looked like. After undergrad, I just wanted to learn more about God, so I went to the Northeastern Seminary, and while I studied there, certain doors opened, and I ended up being a per diem chaplain at a hospital in Rochester. And while I was there, I grew a lot, I learned a lot, and then I learned about hospice and palliative care. I didn't know what that was. And so when I learned a little bit more, tell me more, I want to learn what this is all about. And that's when everything clicked. And I asked my newlywed wife, "Hey, what do you think about med school?" So she was gracious enough to be, ultra supportive. So that was really, really the journey. Everything from there just kind of took its course.
I love hearing that because I think so many times young ones may feel pressured to have that career picked out already. And sometimes that's just not the journey for them, and that's not their discernment that they have to go through. So I think hearing that journey will be so helpful to so many. Thank you for that.
Well, as I've said, hospice is a calling. It tends to choose you, and I am no different. Hospice chose me. It actually chose me when I was in high school. My mother was a therapy dog handler, and we had 4 therapy Irish setters, and she visited patients on the hospice unit that I now work on, but it was at the 5th floor of St. Mary's Hospital is where it was located. And when I was on break as a high schooler, I would go with her and handle one of the dogs. And, I saw this hospice, and I thought to myself, yeah, this is really important work. Someday it's going to be part of my life. Fast forward, I became a nurse. I worked in labor and delivery for most of my RN career and became a nurse practitioner, and then worked in areas like inpatient psych and taught for a bit and did some things. And I was the director of a family birthplace. And it was 1 a.m, and I, for some reason, opened Indeed, and there was a hospice nurse practitioner listing. And I thought to myself, huh, I should apply out of a whim. And I did. And I applied, and I met with our medical director, and she's like, "How does a labor and delivery nurse know anything about hospice?" And I said, "Well, they're not that different. And they're very much a natural process, supporting a natural process, making connections with families in the most intimate, stressful moments, and caring for patients." And she went, "Huh." And I go, "And I'm called to be here. This is where I need to be right now. And she looks at me and she goes, okay, you're hired. And that is how I got to hospice. It was a God moment. Kind of tapped me on the shoulder and said, hey, it's time. And I went back and became part of the community hospice team, and then ended up working in the inpatient unit as well, where my mom had done her therapy dog work so many years ago when I was in high school. So it was a faith journey for sure.
Thanks for sharing that.
I think for myself, in the social work field, we don't focus a lot on gerontology. And so, there's tracks that you can go into in a master's program for child and family mental health. And, and I'll ask students, like, what, age demographic do you want to work with? And they're always like, I could never work with old people. That drives me crazy. But we hear that a lot. And so I teach gerontology courses and focus on that in development classes, because I want our students, I want people who are getting ready to go out in the field to be a little more knowledgeable, and to be a little more open to the joy that can be found in working with people who are older. Yes.
Yeah.
Yes.
There's a lot of wisdom there.
There is. There
lot
is.
to be learned.
I think people. I think that it's a natural kind of condition to be fearful of end of life, and especially I think for young people to be like, oh my gosh, like it's so different, and I can't even picture what that might be like. So trying to keep, and I realize again, hospice palliative care is not just for older adults, but that focus on gerontology for me is really important.
When I was at NYU in the 90s, that's where I did my graduate study, and that's where I made the decision to become a geriatric nurse practitioner. And during my clinical training at that time, I had the honor to go to Mount Sinai in Manhattan. And Mount Sinai is one of the birthplaces in the United States for palliative care. And so not only did I get exposed to practice, I was getting exposed to the studies that were happening at that time. And probably the most impactful for me was looking at an older person who had a dementia diagnosis that was late stage, meaning they could no longer eat or swallow. The body had forgotten how to do that. So they had artificial feeding tubes, and they had a condition known as contractures. And so they really were fully dependent, beds bound and fully dependent. And the research study had a massage therapist who had come in and had done a 30-minute massage treatment and had measures. And if I saw with my own eyes how that person looked before and how that person looked after. And as a nurse, I've always had an appreciation of who has the touch. Right? And we've heard patients say, you got a hand like a foot, as some would say, or whatever terms they would use. But then who has that type of touch? And it just really emphasized to me so much. And so being exposed to that really early on became embedded in how I approached care. But what I lacked was a team approach, because once you left that context and you went elsewhere, not everywhere had that intensity of the context of care that was needed. So fast forward, working in a variety of settings, teaching in various academic units. I was at Wagner College on Staten Island, New York, and somebody said, "Did you hear? There's a part-time nurse practitioner on the palliative care team." And I went, "Is that with Kathleen O'Connor and Dr. Forte?" And they went like, "Yeah, how do you know about that?" And I put in an application because I knew it was part-time and I could do it with my academic position. And I was hired. And it was a interdisciplinary palliative care team with social workers, nurse practitioner, physicians, and a clinically trained pastor. And I was able to do that on Staten Island. And hands down, probably one of the best set of teams that I had ever had the distinct pleasure to work with and inform how I teach and hopefully inform how I handle people, right, on a daily basis, because I think in my world, everybody needs to be palliated.
So true.
Right?
So true.
Thanks again for listening into the conversation. Remember, the dialogue does not have to end here. Take what you've heard, bring it to your own table, and keep it going.